and good afternoon, everyone. I am Dr. Dalia Alabdulrazzaq. I'm an associate professor at the Department of Pediatrics at the Faculty of Medicine at Kuwait University. It is a pleasure for me to join you in this important meeting, and I regret that I can't be with you physically due to the pandemic situation. But hopefully in the future, I'll be joining you with future events. I would like to thank the organizing committee for inviting me to this prestigious conference. And it's a pleasure for me to talk to you in the next 30 minutes or so about assessment and management of short stature in children. Now, this is the agenda for our talk for the next 30 minutes. I'll start by defining short stature in children and give you some hints about diagnostic approach to children with short stature. And then we're going to discuss the most important method of treatment in children with short stature, which is growth hormone therapy, and what is the desired treatment options after starting growth hormone therapy in children. And then I'll end up with some important take-home messages and some suggested readings. Now, I'll be basing my talk on a case that I have seen in our endocrine clinic. Now, we have seen patient YA. He got referred to us in our endocrine clinic a while ago when he was 3 years and 9 months with concerns of being short. Now, a review of his medical history was unremarkable. He was a product of full-term spontaneous vaginal delivery. He was the first child to this family, and his birth weight was appropriate for gestational age. He didn't have any chronic conditions or illnesses, no history of any surgeries, and he was developmentally appropriate for his age, and he was not on any medications. There is no family history of any syndromes or conditions that might explain something hereditary with regards to short stature. We have assessed him and we did a physical examination, and this is on the screen. You can see his WHO growth chart for height. So when he got referred to, as I said, he was 3 years and 9 months, and his height was around 92 standard deviation, putting him below -2 standard deviation, between the -2 and -3 standard deviation. Now, if we take this growth parameter in terms of height, and let me tell you that his weight was at 0 standard deviation, and he had normal weight for age and gender. Now, with this reading of height, this growth parameter, how can we define if this child is short or not? Now, definition of short stature in children, we define short stature in children when height and length is below the 3rd centile. If you're using a chart that uses centiles, such as the CDC growth charts, or also the WHO growth charts that are defined by centiles. Or if the height is less than -2 standard deviation compared to children of the same age and gender, if you are using the WHO growth charts that defines it has a standard deviations similar to what we have used in this case, this defines also short stature. So this is height and length at a certain point in time. However, also we can define short stature over time when there is a decrease in growth velocity of less than -1 standard deviation for age. Now, there are normal charts and normal tables that for each age and gender defines growth velocity. So if you have a decrease in the growth velocity, even though that the height is not below -2 standard deviation or less than the 3rd centile, you can still define it as short stature. And for this child, he was at the time of an assessment, his height was below -2 standard deviation, and he was fulfilling the criteria for short stature. And the workup was initiated to discover the diagnosis of short stature in this child. Now, let me start with you with some of the work that we did at our endocrine clinic, where I practice in Kuwait, about the referral pattern of children with short stature to our pediatric endocrine clinic. Now, short stature is one of the most common, if not the commonest, indication of referral to our endocrine clinic. So what is the referral pattern of these children that got referred to our pediatric clinic? So we did a cross-sectional study of all the referred children between the year of 2008 and 2015. And we included all children that have completed the workup and had a definitive diagnosis with regards to their short stature, and they have complete data that can be analyzed, and we included them in the study. Now, there was a total of 221 children who got referred to us during that period with concerns regarding short stature. Now, as you see here, around 78% met the criteria for diagnosis of short stature, i.e., their height was below the -2 standard deviation, or their growth velocity was below -1 standard deviation. However, which is interesting, and this is what I want to highlight, is around 21%, approximately 22% of children referred to our clinic with concerns of short stature, they were not actually short. They were above the -2 standard deviation, and their growth velocity was normal for their age and gender. And so you see, for our endocrine clinic at that time, around 1/5 of the referrals were unnecessary. Okay, and comparing these children who got referred unnecessarily to our pediatric clinic, we compared them to those who were actually short. There was actually no gender differences. However, they were a bit older compared to those who were correctly referred with short stature. They were at a median height of 9 years. Okay, so as you see here, we have identified that there is a tendency for families as their children grow a little bit taller and approach puberty, they want to get the benefit, they want their children to be taller and get a benefit of any treatment that is possible, i.e. specifically growth hormone, in order to achieve a higher or a taller stature for these kids. And why is that? It's because I think a lot of it is social pressure. There is a lot of social pressure for kids and everybody to be tall, especially boys. It has been reported in the literature that taller individuals are more likely, for example, to be in a leadership position, more likely to show power, and more likely to show an aura of trust. And that's why there is a lot of pressure on the families to have their children, especially boys, to be taller. For example, I see here that I'm one of the biggest fans of the James Bond movies. And James Bond is a hero, and at the end of the film, at the end of the day, he will save all and solve all save all the troubles and problems. And as you see here, all the cast in the previous movies with James Bond were above 6 foot tall. Okay, and a 6 foot is like all of them were more than 180 centimeters in stature. So as you see, we see heroes as being tall. We perceive heroes and leaders and people with power as being tall. There is a lot of pressure the families are under, that their children need to be taller. And this is something that we have to take into consideration when dealing with families who refer their children with short stature. And this is where the importance of public awareness comes in. There's the Growth Awareness Day, which is on September 20th. We have to educate our families and the public in our communities with regards to what is normal growth, what is abnormal growth, what is short stature, and accept that there is a wide range of lengths and statures among children and adults that can be accepted. Going back to our study, with regards to who were those who were actually correctly referred with short stature, what were the causes? Okay, most of the causes that got referred to us with short stature, 33%, around a third, were normal variants, i.e. constitutional delay of growth and or familial short stature. The second most common cause was growth hormone deficiency at around 20%. And the third most common cause was small for gestational age. Now, this was similar to other reports from the literature. And there were other causes, less causes, such as chronic illnesses, syndromes such as Turner syndrome, Noonan syndrome, and others as well. However, the top three in our studied population were, as I said, normal variants in number one, growth hormone deficiency was the second, and the third was small for gestational age. Now, I'll be discussing now the second item of the agenda is in our during the talk is that hints on diagnostic approach for these kids. Now, due to time constraints with this presentation, I won't be able to go through in length about how do you approach a child with short stature. However, I'll be providing hints and then some suggested reading materials that would be helpful for general practitioners, general pediatricians, and whomever sees children with short stature to help them diagnose and assess these children. Now, these are the things that you have to consider in diagnosis of short stature. It's not a one gold standard test that will help you diagnose what is the cause of short stature in any or each child. You have to consider, of course, as any case that we see in medicine, full medical history and growth evaluation and physical examination, clinical investigation. There are some static biochemical testing and basic biochemical testing for growth hormone specifically. And it is one of the things, as I said, is the second most common cause of short stature in our population. And we are looking for growth hormone deficiency in these kids. Dynamic testing for growth hormone secretion, and imaging testing and molecular genetics. So these are the considerations that you have to take into account when you're assessing children with short stature. However, the most important is medical history and growth evaluation, i.e. physical examination. More than 70 to 80% of kids whom you see with short stature, you can get an idea of what would be the diagnosis if you have a full medical history and full growth evaluation. How is that? For example, it is known that children who were, when their height is severe, i.e. less than -3 standard deviation or so, it is more likely that these kids will have a pathological cause of short stature, not a normal variant or even not small for gestational age. It is a pathological cause if their short stature is severe, i.e. less than 3 standard deviation. And this was seen in our cohort of the study that I mentioned with regards to our kids that we have assessed in our endocrine clinic. The height, as you see here, these are comparing the top 3 common differential diagnoses in our study population: normal variants, growth hormone deficiency and small for gestational age. Heights of children with growth hormone deficiency, the pathological cause, were these kids were shorter compared to those with normal variants, and even with those kids with small for gestational age, their height was at around a mean of -2.9, close to -3 standard deviation, and this was statistically significant. So this is one of the things that you can get from the growth assessment is if the child, the severer the short stature, the more likely a pathological cause will be found. Now, I would like to share with you our supplementary referral form that we have established in our endocrine clinic where I practice here in Kuwait, that is Mubarak Al-Kabir Hospital. It is meant to aid the general pediatricians and general practitioners in assessing children with short stature prior to referral to the endocrine clinic. And please feel free to take a picture of this supplementary form. I'll be happy to send it to whomever is interested if you send me an email. Now, these contain some of the most important information and workup that needs to be done for each and every child with short stature, depending on the case. Now, some baseline characteristics and gender, of course, and the height okay, at the time of referral, and also the mid-parental height, i.e. the father's and mother's heights, and using the famous formula to determine their the child's mid-parental height, i.e. their genetic potential later on based on their family. And these are some of the a list that outlines some of the tests that need to be done for children at the assessment at the time, or at first when working them up to diagnose short stature. A complete blood count in ESR, renal function test, liver function test, celiac disease. And I would like to say something about celiac disease. Celiac disease is in our workup in kids with short stature, because there has been literature that some of the kids, even though that they don't have gastrointestinal symptoms, might present with short stature as a symptom and a sign of short stature as a sign of celiac disease. These kids can present only with short stature, and when you work them up, they might have celiac disease. So please include your celiac screening, even if the child does not have any gastrointestinal symptoms, in your workup for kids with short stature. IGF-1, which is the screening test for growth hormone. Vitamin D, as well, as you know, rickets and vitamin D deficiency may lead to delay in growth. Thyroid function test as part of the differential, and bone age, karyotype for girls to rule out Turner syndrome, and if they're depending on the case, any other blood tests or imaging. So these are some of the baseline workup that we advise general pediatricians and general practitioners to do when assessing children with short stature, and have available prior to referring these kids to the endocrine clinic. Now, going back to our case, YA, as I remind you, it was 3 years and 9 months who referred with short stature, and his height was between -2 and -3 standard deviation. And these are the blood work that we did and the assessment that was done for this child at the time of assessment at the endocrine clinic. IGF-1 was low. Vitamin D was accepted. Above 50, we accepted. And above 50, unlikely to cause symptoms and ramifications. Bone age, he had delayed bone age. At the age of 3 years and 9 months, his bone age was around 2 years. We did growth hormone stimulation testing, which I will tell you more about shortly after this slide. His peak growth hormone stimulation level was low at 9.3 milli-international units per liter. And in our clinic, the normal response the peak response should be above 20. Because of this low growth hormone stimulation level, an MRI brain was done, specifically looking at the pituitary gland, and it was normal, and other workup was normal. And because of this, he had low IGF-1, delayed bone age, and he had low growth hormone stimulation peaks at stimulation. This child was diagnosed with growth hormone deficiency and started with growth hormone therapy as per our protocol in the clinic, with a dose of 0.03 milligrams per kg per day, which he is still on till this date. Now, something about growth hormone stimulation testing. Now, growth hormone stimulation testing is not, I would like to stress this, it's not the sole diagnostic test for growth hormone deficiency. You can still diagnose growth hormone deficiency without growth hormone stimulation testing if you have axiological criteria categorizing the child as being short, which we discussed before. It's like a height of less than -2 standard deviation or decrease in growth velocity. Plus, if you have evidence of hypothalamic pituitary defect, for example, developmental abnormalities within the brain, anatomical abnormalities within the hypothalamus or the pituitary, or anything that leads to abnormality within the structure or the development with the pituitary or the hypothalamus, plus a deficiency of at least another pituitary hormone, such as the thyroid or TSH or ACTH or any other hormone that is secreted by the pituitary gland. If you have these three criteria together, and it has to be all, you can define the child as having growth hormone deficiency if he's short, without needing to have a growth hormone stimulation testing. Now, growth hormone therapy. A lot of the kids, as I said, you see from our study, that a lot of the kids sometimes unnecessarily being referred to us for assessment of short stature, and a lot of the families are aiming specifically to start their kids at growth hormone therapy, aiming for a higher stature. So, growth hormone therapy is one of the safest medications that we use in our endocrine clinic, when we have been using it here in Kuwait for quite a while. And it is used for the management of short stature in certain indications. Most importantly is growth hormone deficiency syndrome, which is a syndrome of impaired growth hormone secretion and in action. And action of the growth hormone are on the cartilage, growth plate, leading to growth. And also it affects metabolism and also body composition as well. So it's a syndrome, as I said, that has effects on growth, body composition, and metabolism as part of the growth hormone function. Now, what are the indication of growth hormone therapy in kids? Now, depending on the region and depending where you're from, there are the approved indications in base where you are located. The most common growth hormone indications are growth hormone deficiency, Turner syndrome, chronic renal disease, small for gestational age, and in some countries, idiopathic short stature and familial short stature. And there are other indications such as Prader-Willi, Noonan, etc. So base where you're located, and these are the most common indications of growth hormone therapy in short stature in kids. Now, I'd like to share with you our experience with growth hormone therapy in Kuwait. We have done another study, which we have studied recombinant growth hormone therapy in children with short stature in Kuwait. This was a cross-sectional studies of kids who were managed in our endocrine clinic, and they were on growth hormone therapy. And the growth hormone deficiency was the commonest indication of use of growth hormone therapy in our clinic. And this was similar to our other international literature. Okay, and these are the baseline characteristics of these patients in our clinic with growth hormone deficiency. A mean height of 6.4, a mean age of 6.4 years. They were fortunately younger compared to the total population, which I'm going to mention about later on, the importance of referring these children early on and at a younger age to have a better response to growth hormone. And this is their height. As I said previously, they are usually severe in terms of their growth hormone, severe in terms of their short stature. Their height was minus 2.76 standard deviation. Now, when usually you start growth hormone, we have discussed about the indications. Now, how do you monitor children on growth hormone therapy? Now, there is a lot of protocols that you can follow, and they're available online free of charge. And depending on what society that you follow and what school that you follow. And I'm going to mention one of the protocols at the end with the suggested reading to help you how to monitor these kids with growth hormone therapy. But these are the most important point for an endocrinologist or a physician who is monitoring kids with on growth hormone. First, you have to ensure compliance, which is a struggle and a challenge. Now, compliance usually is an issue with these kids. We monitor this by asking history and measurement of IGF-1 yearly, but also there's other devices that can measure also compliance. Second, we have to assess if there's any growth hormone side effects that the child is suffering from. Usually, I have been doing this for quite a while, and I have a lot of patients on growth hormone. Growth hormone is a safe drug if used correctly and with the right indication. Now, of course, you have to monitor the growth parameters, most importantly, the response in terms of height. And the definition of a good response to growth hormone therapy, especially in the first year, which is the most important year in terms of response to growth hormone therapy, is defined by Professor Ranke. And this is what we follow in our endocrine clinic. A child who gains in a year 0.3 standard deviation in height, or 0.5 standard deviation plus standard 0.5 0.5 standard deviation if he had severe growth hormone deficiency. In 1 year, if he gained this change in height, this is a good response. Puberty status as well, because we know that at the start and end of puberty, the response of growth hormone decreases and the epiphyses close. So puberty assessment is important. You have to monitor the doses per weight and body surface area. Now, the dosing we use in our clinic is by weight, and most of our protocols is by weight or to a lesser extent body surface area, and this is what gives a better response. We monitor also IGF-1, which is the screening test for growth hormone. And the way I do it is when I start the child on growth hormone therapy 1 month after, I usually test IGF-1 to give me an idea at the dose, if it is appropriate or not. I don't wait 4 months after to see the child and see the response in height, because we know that the first year is crucial. So this is what I do. After 1 month, I do a level of IGF-1 and adjust the dose accordingly, and I do it yearly thereafter. Now, growth hormone therapy, growth hormone leads to hyperglycemia in predisposed kids and adults. And with the rising incidence of obesity here in the country and in the Gulf area and Middle East, and also with the rise of the incidence of type 2 diabetes in Kuwait and other nearby countries and in the world, most of our kids are at risk of type 2 diabetes and hyperglycemia, and especially if we have growth hormone therapy on top of it. So most of the kids in our clinic will have screening tests with blood sugars and hemoglobin A1C yearly if they are on growth hormone therapy. And we do a bone age at diagnosis and near puberty to see if the epiphyses had closed or not. Now, what are the side effects? As I said, side effects of growth hormone therapy. Relatively, it is a safe medication if used under supervision. At least it is an injection. At least lipoatrophy, bruising at the injection sites, but usually these are at the start, and after the families get used to these administration of this medication using the pen, usually this will be resolved. It can lead to increased intracranial pressure, especially if used inappropriately or with higher doses. So it might lead to headaches, nausea, and vomiting. It might lead to hip and knee pain, limping, gynecomastia, progression of scoliosis, kyphi, edema, and allergies. In our clinic, in the same study, we didn't have any major side effects. One child had an allergy to one brand of growth hormone, and this is what I recommend if you get an allergy. We sometimes change the brand or pre-medicate with hydrocortisone or histamine. If you get any other side effects, maybe you can stop and then later on restart at a lower dose, or maybe from the start lower the dose. But side effects with this medication, it's usually, from my experience, I haven't really had any issues with the children that we're following. Now, what are the desired treatment options or the treatment outcomes in terms of with kids who are starting on growth hormone therapy? As I said, specifically for growth hormone deficiency, it was an abnormality in growth in children, and then later on in adults, maybe body composition or metabolism. So the aim of growth hormone therapy is to normalize these three components. And for other indications, which are non-growth hormone deficiency, is to achieve normal height, adult height, or near normal adult height, appropriate for this child and his genetic potential. Now, this is the desired treatment outcome that any endocrinologist who is starting a patient on growth hormone would like to see. So this patient was started at 3 years and 9 months at the time of assessment with growth hormone. As you see, within a few months, his growth velocity has increased. And after 1 year of therapy, he was no longer short by definition. His height was above -2 standard deviation. This growth chart goes to the age of 5 years, and this is his recent growth chart. I have seen him 2 or 3 months ago, and he's almost 11. And as you see, he continued to be compliant to his medication and under medical supervision with us. And his recent height was at 0 standard deviation within his parental height potential, and it normalized. Now he continues to be on growth hormone. So as you have seen, and the first year is a key in the treatment of growth hormone. And what are the factors that govern such good response in these kids? Now, going back to our study, we studied also the response to growth hormone therapy at 1 year in our kids. And this is the baseline, basically as you remember, the mean height at initiation of growth hormone for these kids were minus 2.76. And this is after 1 year. The mean for these kids were minus 2.11 standard deviation. And after adjusting for all other baseline factors at the time of initiation, we identified factors predicting response at 1 year. In our study population, age at initiation was a key factor in getting a better response to growth hormone therapy, with an odds ratio of 0.56, less than 1. So that means that it is an inverse relation. It was significant, i.e., the younger the child at start of growth hormone therapy, the more response that you can get. And this is one of the things I would like to stress to the families and to the public, that if a family has a child who and you think that he is short and have concerns with regards to being short, please refer him as early as possible. So if he qualifies for growth hormone therapy, the earlier that this boy or girl start on growth hormone therapy, the better the response. Not to wait later on near puberty, which had happened, that you delay seeking medical attention, because if you start the growth hormone as early as possible, that the governs gets a better response. Now, when do we stop growth hormone therapy in kids? These are the indications where to stop growth hormone therapy in kids. If the patient wishes, and there are some patients, they don't, growth hormone is a daily injection, and some of it is quite, although it is painless and it's with the pen, but sometimes some families don't like for the child to have any medications, or they find it difficult, or they cannot cope with it. So as patient wishes. Now, if there's no response to growth hormone therapy, and that is by growth velocity decreasing to less than 2 or 2.5 centimeter per year, that means that there is no response and you should stop growth hormone therapy. If there is fusion of the epiphyses when you do a bone X-ray, i.e. the wrist X-ray, and it's usually for bone age for girls around 15 years and 16 in boys, and if you have attained the desired height. Now, features, as I said, growth hormone disease deficiency is one of the commonest causes of pathological cause of short stature in kids. And in adults, usually when we stop growth hormone, but however, these kids with growth hormone deficiency as adults, they might require growth hormone therapy, because growth hormone disease deficiency in adults may have reduced lean body mass, reduced bone mineral density, decrease in muscle strength, diminished quality of life, abnormal lipid profile, and lower cardiac function, and might benefit from growth hormone therapy. And so we referred these kids who have been on growth hormone and had the diagnosis of growth hormone deficiency after completion of therapy to an adult endocrinologist, where they test growth hormone therapy they have different protocols, and one of the protocols I'm showing here in the screen, they usually have a period where there's washout of growth hormone, no growth hormone, and they retest growth hormone secretion. And if they still have growth hormone deficiency, they will restart growth hormone therapy, and it is an adult indication. As I said, adherence is a huge obstacle in management of kids with growth hormone therapy, because the chance is high of having lack of compliance and non-adherence, as it is a daily injection. The duration of therapy is very long, it's many years. So adherence is high in the important but less dose-dependent first year. And 1 missed dose per week in the first year leads to a loss of a height gain of 0.11. And if you add these up, it might lead to really a loss of a great potential of getting height for these kids who are on growth hormone therapy. Most common reasons for poor adherence to therapy. There are many cases. So those who have, if you have a child who's in growth hormone therapy and they're not adhering to therapy, you have to look at
what are the causes and address them appropriately, and then maybe you can get, after management of any of these reasons, you might get a better compliance. Maybe there is a lack of understanding of the primary disease. Maybe it's a difficult period. It is an adolescent, for example. They don't have a better idea of the length of treatment anticipated. They are feeling down because of poor adherence regarding growth responses, inadequate support, pain and discomfort in the injection site, fear of needles, lack of choice of injection devices, lifestyle that is for the families who are inadequate to support a child with growth hormone deficiency, inconvenience of the injection schedule, and dissatisfaction with growth responses. So I would like to, we have talked about now short stature, and we have went through the agenda. At the end, I would like to recommend some of the readings for you that is really helpful. This is a review article that is published by our colleagues. It's Diagnosis and Management of Growth Disorders in the Gulf Cooperation Council, GCC. It's very important, very informative about current procedures and key recommendations for poor practice when dealing with these kids. And this is the latest Pediatric Endocrine Society guidelines for growth hormone therapy in kids. So I would like to conclude my talk that diagnosis and management of children with short stature is challenging. Precise application of anthropometric principles, integration of test results, and comparison to medical history is imperative, and growth hormone therapy had not only led to improvement in final adult height, but in metabolism and body composition as well in patients with growth hormone deficiency, which is the most common cause, pathological cause of short stature in our kids. Thank you for listening, and this is my email. I'll be happy to receive any of your questions and feedback through this email, and I'm looking forward to joining you in the Q&A session. Thank you.